Good morning, everyone. I think we're going to go ahead and get started. I'm Lindsay Voss, one of the medicine chief residents. Dr. Page couldn't be here this morning, so I have the honor of introducing Dr. Mandelbrot, who will be giving our talk. Dr. Mandelbrot did his undergraduate training at Harvard before going on to UPenn for medical school and residency. He then did his nephrology fellowship at the Brigham and Women's Hospital in Boston, where he stayed on as faculty before joining us here at UW in 2014. Dr. Mandelbrot is incredibly well published. I did note his first publication on his CV was his Harvard honors thesis focusing on neurotransmitters in the lobster, which it sounds like had some culinary benefits. But luckily for us, he then moved on to transplantation science and nephrology research, and it's been incredibly well published with multiple book chapters, 89 publications to his name. He's been an active mentor and teacher throughout, and we're very lucky to have him here today to talk about the living kidney donation.
Morning, everyone. I want to thank the organizers of this lecture series for inviting me to come speak about living kidney donation. So as my title implies, what I'd like to talk about this morning is a little bit of the history and background on living kidney donation. Talk a little bit about some of the trends and where we've ended up with and some current practices and evaluation of risks involved with live donation. Then I'm going to move on to some of the clinical questions that have come up, some of the research approaches that have been taken to answer these questions, including a little bit of my own work. And if I have time, I'm going to talk about the UW Living Donor Program as well. So I think it's sort of inevitable to, if you're going to talk about the history of live donation, to start off with this picture, which shows Joseph Murray performing the first successful kidney transplant in humans. And so this was from a live donor who was the recipient's twin. And Dr. Murray went on to do cadaveric kidney transplants and be involved in a number of very important pioneer work in kidney transplantation in general. And for this work, he received the Nobel Prize in Medicine in 1990. What's interesting to me is that this initial surgery is not remarkable so much for the technical aspects. He was able to plug in an artery, a vein, and a ureter. Other people were capable of doing that, and he practiced in animals. And it was also not so much the immunological advances that he made, since this is a perfect match. These are twin transplants, and there was actually no immunosuppression used at all. But what I think is still actually relevant to today, to our practice of live donation, and was particularly pioneering at the time, was his very extensive efforts in evaluating the live donor. So obviously the live donor was evaluated from a medical point of view, a surgical point of view, but also from a psychological, social, ethical point of view. And in fact, Dr. Murray sort of pioneered the concept of an independent live donor advocate, which is a concept that remains with us today. And in fact, the government requires that every time we evaluate a potential live donor, that donor has an independent live donor advocate. And the idea there is that the advocate has no conflict of interest, has no interest in protecting the welfare of the recipient, and has no interest in promoting the program overall, but really focuses on advocating for the donor. And so this concept dates to 1954, and again, the government requires that to be in place for every donor evaluation. So I came across this picture recently, which is very striking to me because it shows both the donor and the recipient, so Richard and Ronald Herrick, about a year after this surgery. And I think it's pretty much impossible to tell which is the donor and which is the recipient. And it's also impossible to tell that they have any health problems. What's amazing to me, so Richard, who it turns out is the one on the left, this is at a time, so 1954, when there was no such thing as chronic dialysis. So he would have presumably died of his kidney disease, but he went on to live 8 years, got married, had kids, had a productive life. And even more striking is the donor, so Ronald, ended up not dying until 2010 at the age of 79, so of heart disease and obviously of causes unrelated to his live donation. So this is a very auspicious start to the field of live donation. And of course, over the subsequent 60 years or so, there's been dramatic changes and expansion in the field of kidney transplantation and live donation. And in fact, I think a lot of people would argue that kidney transplantation has been so successful, it's such a routine procedure in many ways with very high success rates, that we're a victim of our own success. So what this graph shows is that we keep wanting to list more and more people for transplantation. So this shows in the year of 2000s, the top line shows the increased numbers of patients put on the wait list, which almost doubled just during that decade. But there's a dramatic shortage of organs to transplant. So you can see in that pink line the slight increase in number of transplants, but obviously not nearly enough to keep up with the demand or the number of people being listed for transplantation. And so one of the consequences of this organ shortage is this third line at the bottom, the yellow line, which shows an increase in the number of deaths on the waiting list. And of course, the more and more people are listed, the longer are the waiting times for a transplant. So live kidney donation obviously plays a critical role in helping to meet the shortage of organs to transplant. And there's also some critical benefits to the recipients of getting a live donor versus deceased donor transplant. And I've just kind of summarized some of the key benefits here. The main one is for a live donor transplant, there's no waiting time. This can often be done even before the start of dialysis, so-called preemptive transplants. While the waiting times for a deceased donor kidney, depending on the blood type and region of the country, can range from on the order of 2 years to 6 years, and sometimes even longer. So much less time to wait to get the transplant. And then after the transplant's performed, a live donor kidney provides much longer graft survival. The mean time is on the order of 15 years versus 10 years overall. And that's probably not surprising. The live donors have been carefully evaluated to be healthy, as opposed to someone who just passed away. And in addition, the cold ischemia time, so the time that the kidneys are on ice before being transplanted, is much shorter with a live donor kidney. And so that means there's less acute kidney injury, less delayed graft function, and it turns out that that's associated with less rejection. So all these factors combine to provide much better patient survival for recipients of live donor versus deceased donor transplants. So I think it's fair to say there's really no controversy that receiving a live donor kidney transplant is the best option for someone with ESRD. And this is something that we try to repeat at all stages of progression from chronic kidney disease to end-stage renal disease and the evaluation for a transplant. But of course, unlike every other specialty, I would argue every other specialty in medicine, when we are doing a live donor transplant, we are potentially endangering the health of one person for the benefit of another. So really the focus of the field and the focus of my talk today is how do we assess the risk to live donors and how do we protect the health of live donors. So there were a number of studies, early studies, that looked at how do former live kidney donors do in terms of patient survival. This is a very famous study, one of many, that followed former donors. This is in Sweden, where they have very complete healthcare information on the entire population, as well as follow-up information. And it had this kind of catchy title of Kidney Donors Live Longer. And what they did is they looked, again, out to 25 years after donation. And this top line here is the actual survival of former donors with some confidence intervals. And they compared it to an expected survival and suggested that donors live longer. Now, of course, it doesn't mean that the process of donating a kidney is what allows you to live longer. This is very minimally controlled. So they controlled for sex and age, but nothing else. So this is essentially comparing donors to the general population. And not surprisingly, the general population includes people with chronic kidney disease, heart disease, diabetes, et cetera. So this carefully selected group of donors, which was selected not to have any of those factors, ended up living longer after 25 years. This is an issue that I'm going to come back to again and again. The outcome of these studies depends critically on how you select your controls. But certainly this was fairly reassuring in terms of the long-term outcomes of donors. Then a later study in the New England Journal in 2009 looked at a much bigger population in the US and found that these former donors don't have any different survival from the general population. And in this case, they controlled slightly better, but still only controlled for age, gender, and race. So again, so you can see from this slide that the survival is similar. The main criticism of this study was that they didn't, again, control sufficiently for all the factors that go into the donor evaluation, and that mean that the donors start off being healthier than the controls. But again, fairly reassuring that there's not a strong signal of bad outcomes after live donation. And the study also looked at a subset of their 4,000 or so former donors and looked at some detailed metabolic factors. And the way this was presented is it was reassuring that even the former donors compared to the controls in a number of factors, which I've circled here in red, were actually turned out to do better in the future than the general population. They had slightly lower systolic blood pressure, slightly less albuminuria, even slightly better glucose and cholesterol, so suggesting that they do better in the long run. Of course, the other way to look at this is that it suggests that these are donors who started off with better metabolic parameters. They had better blood pressure, better sugar, et cetera. But at least for this follow-up, which I think went out to 40 years, somewhat reassuring that the controls, that the donors are doing well. But again, the criticism, this subset of the whole group in this study was slightly better controlled. They also controlled for BMI, but still many other factors were not looked at in the follow-up. So there was another study that came out around the same time that looked specifically at surgical risks. So instead of long-term survival of donors, short-term risk of death. And they came up with this number, which has now been reproduced in a number of different places, that the risk of death within 90 days of donor nephrectomy, and they looked at a very large number, over 80,000 donors, turns out to be 3 out of 10,000. And what was interesting is this study put this in context compared to some other surgical procedures, including laparoscopic cholecystectomy, which the death rate is about 5 times higher. And interestingly, the post-op mortality for a non-donor nephrectomy, so a nephrectomy for cancer or other kidney disease, turns out to be on the order of 100 times higher. And then the final comparison is the risk of death within 90 days among matched controls from NHANES. So the NHANES population is going to come up several times. And in this case, they did control carefully. They excluded anybody from the controls that had diabetes, hypertension, or heart disease. And they came up with this risk of death of 0.4 per 10,000. And so I actually allude to these numbers essentially every time I do a donor evaluation. I'll be more or less specific depending on the characteristics of the patient. But they need to know that there's this risk of death. And then to put it into context, if you look at that risk of death of a matched control, of a young, essentially a healthy person, if you do the math, after 2 years or so, the risk of death of a healthy general population individual is the same as the risk of donor nephrectomy. So presumably from car accidents, from gun violence, from developing new disease, there's a certain baseline risk of death even if you start off healthy. So this is to put it into context in the donor evaluation. So I think not surprisingly, given these multiple studies that were quite reassuring about the safety of live donation, you can see that over sort of a broad period of time, 30 years or so, the number of live donors in the US increased substantially, more than 3-fold. And in fact, at one point in 2002 or so, actually surpassed the number of deceased donors. So these are counting donors, not kidneys. So a deceased donor will typically have 2 kidneys that will be used as opposed to 1 from a live donor. But either way, it makes the point that live donation overall has increased very substantially. But one point to make is that when I first started showing this slide, I didn't have quite as much data in the last few years, and it looked like there might be a downtrend, but it wasn't clear whether it was just an aberration, a blip, or was truly a trend. But as time went on, what we found is that there was this, between 1988 and 2004, this more than 3-fold increase, but that between 2004 and 2012, there was actually a 15% decline in live donation. And so my colleagues and I wanted to look at this a little bit more in detail and try to understand which subsets might be most affected and what might be causing the decline in live donation. I'm not going to go through this review in detail, but I think I'm listing here a few factors that almost certainly contribute to that decline. So one is the rising rates of various risk factors for chronic kidney disease, as well as chronic kidney disease itself in the general population. And I'll show a little bit of data in a minute. Another factor has to do with a change in 2005. So again, the decline started in 2004, so the timing is fairly close to it. There was a change in the allocation system to prioritize pediatric recipients. And so the thought is that even though this is a change that all of us essentially support and continue to support, there was a thought that pediatric recipients would no longer have as much of an incentive to get a live donor transplant from a parent or a relative if they were able to rapidly get a good quality deceased donor kidney transplant. So this just sort of brings up the point that often changes in the allocation system can have unintended consequences, and some of those consequences have actually affected in various ways the field of live donation. And then the other point I want to emphasize has to do with financial issues with live donation. And when we looked at the different subsets, we found that the decline was greatest in live donation among low-income groups. And there was the so-called Great Recession that started in 2007. So it wouldn't explain what happened, obviously, in 2006 and before. But the fact that the decline was greatest in the low-income groups, and there was also an early study that suggested that, and I'll talk more about costs associated with live donation, but already some estimates that the average expense to a live donor is on the order of $5,000 if you include direct and indirect costs. And that corresponds to greater than 1 month household income for over 3/4 of potential donors. So there are some potential financial disincentives, again, that I'll come back to later. So this shows one of these heat maps that I imagine most of you are familiar with, showing the rates of diabetes over this 15-year period. So you can see that in 1994, for example, in Wisconsin, the rate of diabetes was less than 4.5%, and by 2009, had gone up to this 7.5 to 8.9%. So this the heat maps of obesity would look very similar, and there are also similar increases in CKD. So obviously, when there's a general population of so-called healthy people that's being evaluated as potential donors, if there's high rates of CKD or CKD risks, there's a reason to believe that there'd be lower rates of live donation. Now, the other factor that may have contributed is some of the more recent studies that have looked in more detail at the risks of live donation and have actually brought up slightly greater concerns about what those risks are. So the first, I'm going to talk about a number of studies. The first one came out in Kidney International in 2013, and they looked at a little over 1,900 donors. It was just at a single center, and it's in Norway. So how well this applies to other centers in other countries is somewhat questionable, but it was a well-designed study in that they carefully controlled, again, for all those factors in the control population. They excluded anybody with diabetes, hypertension, heart disease, et cetera, that should not be really compared to the former donors. And when they did this, they found that the relative risk of ESRD in these former donors was 11.4. So a quite high relative risk. What's interesting is that in the living donor field, what we've always been concerned about is that by having just one kidney, that remaining kidney would tend to have hyperfiltration injury, hypertensive injury, and then in the long run, we would get proteinuria, hypertensive nephropathy. But what they found in this study, which is actually quite interesting, is that all 9 of the donors who developed ESRD were actually family members of the recipients. And most of them who had ESRD actually had ESRD from immunological causes, so things like lupus or vasculitis, or something that you really would not think that the incidence of those diseases would be affected by having donated or not. So, one potential explanation is that what we're looking at here is an increased relative risk of kidney disease, which may be related to simply related to a family history of kidney disease, rather than some sort of hyperfiltration injury over time. But still a signal that's worth looking at. And the same study looked at all-cause death and found an increased risk of all-cause death, 1.3 hazard ratio. And a lot of that all-cause death was from cardiovascular death with hazard ratio of 1.4. So the authors speculate that that increased risk of cardiovascular disease may be related to the lower GFR. We all know that after kidney donation, there's some hyperfiltration and increase in function of the remaining kidney, and donors typically end up with something like 70% of the function that they started with. And whether that would translate into higher cardiovascular disease the same way as we know chronic kidney disease is associated with cardiovascular disease is not clear, but that's what this study suggested may be an issue. The counter-argument would be that this may be just looking at if you have a family history of cardiovascular disease or kidney disease, you may have a higher risk of eventually developing cardiovascular disease yourself. So the other study that came out shortly after that was a US study, much bigger study, looked at 90,000 former donors and tried to estimate the lifetime risk of ESRD. And what's shown here is they looked at 3 different populations. So the top line shows unscreened non-donors, which basically means the general population. And you can see that over a lifetime, the risk here of ESRD is on the order of 300 out of 10,000, which is 3%. And 3% is roughly the number that I've carried around for many years as the lifetime risk of ESRD in the general population. The risk of ESRD in live donors is something like 4 times lower. It's a little bit less than 1%, 0.9% or so. But the striking finding here was that healthy non-donors, which means the controls, that they excluded all those factors, diabetes, hypertension, the risk of ESRD is something like 6-fold lower here. And it's interesting that this paper actually nowhere talks about relative risks. They really focus on the absolute risk, and they correctly point out that the absolute increased risk is probably on the order of 0.7% increased risk of lifetime ESRD. But still brings up the concern as to how much increased risk there is of ESRD from live donation. Now, I think the key take-home points are that the relative position of these 3 lines, I think they're not controversial. Clearly, the general population has a higher risk of ESRD than former donors, and former donors are not going to have a lower risk than controls. There's going to be some increased risk. What's not clear is exactly how low that line really is. And in fact, I mentioned earlier that some of the early studies were really not well controlled, not sufficiently controlled for the health of the donors. I think they may have actually somewhat over-controlled in this particular study. And if you look at the appendix, which most people probably don't look at, they have a whole list of things that would have excluded anybody from being in the control group. And I put red dots next to some of them just to highlight them. So anybody who would have had a history of asthma, any skin cancer, any hypertension, any diabetes or borderline sugars even, any history of kidney stones were excluded from the control population. But people that are in the field and do donor evaluations know that we often do accept people with borderline hypertension or even a history of hypertension, somebody with a thyroid cancer that was resected uneventfully would be considered as a donor. So there's a number of factors here that made the control group really cherry-picked, extremely healthy, and possibly lowered that risk in the control group a little bit more than if they had been less selective. And of course, there's never going to be a perfect study. There's never going to be a randomized controlled trial of donation versus not donation. So the exact risk is mostly based on these estimates. But I think overall these studies do give you an idea of the risk. The other issue that has come up for many years is as to what is the risk of pregnancy after live donation. And there was a very prominent paper published, again, in the New England Journal a few years ago that looked at this. And they found that if you look at their primary outcome, which is either gestational hypertension or preeclampsia, there was a statistically significant increased risk of these outcomes. If you look at the individual outcomes, gestational hypertension and preeclampsia, the p-values either just reached statistical significance or didn't quite, but the primary endpoint did. And these other endpoints, there was no statistically significant increased risk, cesarean section, hemorrhage, et cetera. But I do think this is a study one of those rare studies that essentially overnight changed what we say when we do a donor evaluation. In other words, a woman of childbearing age who wants to get pregnant should know that there is a slight increased risk of hypertension or preeclampsia. And I guess the last of these studies that I wanted to mention is probably the least prominently published, but in some ways I would argue is actually the best of the studies, because all the studies I've talked about so far are retrospective. They're database analyses or single center studies, but all retrospective. And this is really the first prospective study. And so this study from Kasiski et al. Enrolled about 200 donors and 200 controls. And the controls were not perfect, but they were pretty good. So they were patients who had been at least partially evaluated to be potential donors, had lab tests, blood pressure, but not the complete donor evaluation. But at least the data that was available suggested that they would have been able to be donors. And so they've followed these out so far for 3 years. And this shows, again, the decline in GFR with donation, about 30% decline. It's also interesting that it's a bit too early to tell, but there's actually a slight increase in the GFR. We've all been concerned in the field that, well, we know that GFR over decades of life decline. We've been concerned that if we have do a donor nephrectomy, that remaining kidney will have an even more rapid decline. But this is one of several studies actually that shows, at least at the first 3 years, there does not seem to be an accelerated decline. But what they did in the study is look very carefully at a large number of lab values in these former donors and controls. And I'm not going to show this whole table, but just a few selective results that they have. So if you look at the donors and controls uric acid level, the donors after 3 years actually have slightly higher uric acid. When I first saw this, I wasn't sure that it would be clinically significant, a difference between 5.5 and 5. But there's actually another retrospective study that came out around the same time that suggests that former donors may have slightly increased risk of gout. Serum potassium, there's a statistical difference, but clinically I'd argue 4.17 versus 4.1, probably not clinically significant. Calcium's the same. Phosphorus is actually interesting. They found that the former donors actually have a lower phosphorus than the controls. It's actually in the opposite direction of what you'd expect. When you get CKD, progressive CKD, you tend to get higher uric acid, higher potassium, and higher phosphate, not lower phosphate. So that was confusing. I don't think the authors or anybody else has really been able to explain that. It does sort of make you wonder how reliable this information is when you're getting statistically significant differences. But the PTH was also in the direction that you would expect. The donors had slightly higher PTH than the controls. So we're going to have to get more data over time and see how much this pans out. But again, a signal again that there may be some early signs of kidney disease in these former donors. So to get to the sort of practical question of how do we evaluate donors? So this is something that I and many of my colleagues do literally every week, and we have to decide where to draw the line in terms of accepting or excluding a potential live donor. So as I said, we're never going to have randomized controlled data. What we would like to have is long-term follow-up from prospective trials with large enough numbers of donors and controls to be able to assess the impact of each of the various factors, whether it's hypertension or sugar or BMI. But as I mentioned, we really only have that one prospective trial, relatively short follow-up so far, but we're starting to go in that direction. But we really haven't had that in the past, so what we've been doing for many years in the donor evaluation is extrapolating from large studies of ESRD in the general population. There are a number of short-term, uncontrolled, often single-center studies of former donors suggesting that various BMIs, donors with various BMIs or various blood pressures, at least after 1 or 2 years, do fine, but of course doesn't really give you that much reassurance. And to some extent what we do is to see what other people are doing in the field. And it turns out that doing that, looking at what other people are doing, is actually kind of a useful exercise. If you find that everybody in the country is doing the same thing, that suggests that there's pretty good data to guide everybody as to what they're doing. But if you find out that everybody's doing something completely different, that really suggests that there's no good data to guide us, and that suggests that that's an area of particular interest for pursuing research studies. So just to get at that a little bit, We did a study a number of years ago where we surveyed every kidney transplant program in the country and asked them a long series of detailed questions about how they approach the live donor evaluation. I'm just going to show a few of them. And so this is a good example. When we asked, what is the program's cutoff for hypertension, you can see that the most common answer was anybody who is hypertensive and taking medication would be excluded from donating. But almost as many programs said they would only exclude a candidate if they were taking 2 or more medications. In other words, would accept a candidate taking 1 medication for hypertension. Almost as many also would exclude people with borderline hypertension. So you can see very wide variation because we really don't know what is the right cutoff for accepting a donor with respect to hypertension. We also asked about creatinine clearance cutoffs, and it turned out that there had been an earlier survey that asked a subset, small number of these questions 12 years before our study, and we were able to directly compare the results in 2007 to 1995. And so what you can see is in 1995, the vast majority of programs used 80 as a cutoff, 80 milliliters per minute. But a substantial number, a little over 20% of programs used 60 milliliters per minute as a cutoff, and there's even a few programs that use 40 as a cutoff. I see some eyes widening, and I think that actually shows a potential benefit of these surveys. I think these programs probably realized that they were really outliers, and also over the intervening time there was a lot more attention. The whole CKD staging came into use, and a lot more attention to the concept of nephron mass. But so regardless, you see that by 2007, even more programs are using 80 as a cutoff. And this is a question that I had added on as to how many programs used a cutoff of 2 standard deviations below the mean for the age of that potential donor. And I'll show a little more in detail why I did that. The other thing I want to mention is the question has often been asked, why did it end up that 80 was the cutoff? And I think one of the main reasons is that for many years people assumed that 80 would be a reasonable approximation, that if you got a kidney from a live donor with more than 80 milliliters per minute, that would almost certainly be better than getting a kidney from a deceased donor. And this study actually confirmed that. It shows 3 groups. Recipients who got a kidney from a live donor with less than 80 milliliters per minute, a live donor with greater than 80 milliliters per minute, or a cadaveric donor. And you can see that the line that separates is the live donor with greater than 80 milliliters per minute. So less than 80 milliliters per minute is similar to cadaveric donor. So this is to go back to some data that I alluded to on the well-known decrease in GFR with aging. And this has been done a number of different ways of measuring kidney function, but the general trend is very consistent. So you can see that every decade of life, in this case this is measured by creatinine clearance, the creatinine clearance declines by in the order of 5 to 10 milliliters per minute per decade. And when you have a big population and you have a mean, you can calculate a standard deviation, and then you can calculate a mean creatinine clearance for that age group minus 2 standard deviations. And the idea is that if you have a potential donor who has a creatinine clearance below that cutoff, that means they're in the bottom 2.5% of that age group in terms of kidney function, and you have to wonder whether it's safe for them to donate and whether they may have some kidney issues themselves. And it also points out the point that I've made many times, that using a cutoff of 80 milliliters per minute for everybody, to me at least, doesn't make sense. If you have a 25-year-old who wants to donate and only has 80 milliliters per minute of kidney function, you got to wonder, that's actually below 2 standard deviations below the mean for that age group, and you've got to really wonder if that's safe for that young donor to donate. In contrast, if you have a 65-year-old with 80 milliliters per minute, that should be fine. That's well within those 2 standard deviations. So this is my personal approach. This is not consensus by any means, but my approach is that donors should have adequate kidney function both for themselves and for the recipients. And that's obviously a general principle with all these aspects of the donor evaluation. We want to maintain donor safety as well as recipient benefits. And so generally speaking, I use a cutoff of 2 standard deviations below the mean for age as a way to assess donor safety. And I use a cutoff of 80 milliliters per minute from the perspective of the recipient to make sure they're getting sufficient kidney function. Now, the other point to make is with all these cutoffs, they should not be applied too rigorously because it's very easy to find exceptions to all the cutoffs that you make. So, for example, if you had a 65-year-old who wanted to donate to their spouse, and the alternative for the spouse would be to wait 5 years on dialysis, if the potential donor had 75 milliliters per minute of kidney function and they were 60 or 65, I think most people would agree that that would be a perfectly reasonable donation to allow to proceed, both from the donor's perspective and the recipient's perspective. Now, some of the answers or some of the aspects of donor evaluation are much less controversial. So I think, for example, albuminuria, it's well known that albuminuria is a very strong predictor of ESRD. And the cutoffs have been around for a long time. They're very standard, 30 for the albumin-creatinine ratio, 30 milligrams per gram defines microalbuminuria, and 300 defines macroalbuminuria. You can see that when you get to 30 and above, the relative risk of ESRD goes up dramatically. So I think most programs actually use the same cutoff. Even though it may be that the difference, there's probably data that when you go from 30 to 10, it may actually make a big difference between 29 and 10, for example, in terms of the relative risk. And there's, so basically the lower the better, but still 30 is a fairly common cutoff, and there's some good data to back that up. The other thing we asked in the survey sort of gets at this question of when you evaluate somebody, you don't want to apply any of these cutoffs too rigorously. You really want to evaluate the entire donor. If an older donor has hypertension or borderline hypertension, that may be a perfectly reasonable donor to accept. But if you have a younger donor who has maybe doesn't quite reach the cutoffs of blood pressure or glucose or BMI, but has a number of risk factors, you look at the whole context, and that may actually not be a good idea to accept such a young donor. And so we asked the recipients of the survey how flexible they would be in general in applying the various cutoffs based on younger age. So if there was a young potential donor, you can see that from this that essentially all programs would be relatively or extremely not flexible. While in contrast, if there was an older donor, the programs would be much more flexible. So this has been an idea that's been around for many years and I think continues to be important. So clearly there's a lot of questions that remain as to how much hypertension, how much obesity, hyperglycemia, et cetera, should preclude donation. And as I've shown just from these survey, when there's not good data to guide decisions about where to draw the line, practices tend to vary very significantly. And the other thing is that many people have noticed that as time has gone on, there's gotten an increased amount of comfort level with live donation in general. There's been a tendency to accept more and more medically complex donors. By medically complex, I mean a little bit of hypertension, a little bit higher BMI, et cetera. So because of these factors, many people have called for more and better long-term follow-up of live donors. So this is to remind you kind of the status of long-term donor follow-up. So UNOS, the United Network of Organ Sharing, has a policy regarding transplant recipients, so not donors, that all recipients need to have data reported to UNOS indefinitely. And the result of that is this very large and very high-quality database for recipients. The UNOS policy for former live donors is to report data at discharge, 6 months, 1 year, and 2 years. And many people have pointed out that what you really want for live donors is long-term follow-up because that's when the problems will emerge. It would be quite unlikely, even if you take a very high-risk donor, to see problems in the first year because they're still basically healthy people. So we did another survey, again, of all U.S. transplant programs, and we asked a number of questions about barriers to living donor follow-up and also got some data on how often that data is obtained. And what you can see is that at the early time points, essentially all donors are getting their post-op visits at the transplant center. But as time goes on, there's this very significant and dramatic decline in how often programs are seeing these donors. And the truth is that they're not, at least at this time, programs were not getting the data by other means, even when they didn't see them. So because of this data and other data suggesting very low rates of collecting data on former donors, there was this consensus conference on live donor follow-up that was in 2011. So I attended this as a representative from the American Society of Nephrology, and I was very struck by how much controversy there was about this issue. There was very strong feelings about very different approaches being better. So one of the results of this meeting, which was attended by UNOS and the NIH, was that there was a set of follow-up rules in 2014 that UNOS put out that instead of allowing centers to basically say we couldn't follow up the donor because we couldn't find them and just leave it at that, which resulted in very little data being reported, the latest requirement is that living donor follow-up data, so for example a creatinine, has to be reported, even up to 2 years, in 70% of the former donors. Now, again, a lot of controversy about this rule. I think the term unfunded government mandate came up quite repeatedly. It's a lot of work for transplant programs to track down these donors and report the data. So an alternative that was proposed at that meeting was that there would be no more requirement for transplant centers to report living donor follow-up data, but that there would be a separate registry that would take care of that, that would focus solely on collecting this living donor follow-up data. And so HRSA is the Health Resources and Services Administration. Some of you may not be familiar with, but it's one of the branches of the Department of Health and Human Services, just like the NIH is one of the branches and NCI is one of the branches. And HRSA is the branch that funds and regulates all of kidney transplantation. And so more recently, HRSA has been interested in looking at this possibility of having a separate live donor registry. And I'm actually on the steering committee that's looking into feasibility and a number of other issues. And it may be that that's the way we end up doing things. Clearly a lot of interest in better long-term follow-up and complete follow-up to get detailed information to better assess the risks of live donation. So the next thing I want to talk about is a study that I started a number of years ago before coming here when I was at the Beth Israel Deaconess Medical Center. And this is the Kidney Donor Outcomes Cohort, or KDOC study. And so this was set up with my colleague Jim Rodrigue. And the collaborating centers, a multi-center trial with Maine, Montefiore, Rhode Island, University of Iowa, and University of Arizona. And if you want to find out more about this study, you can go to our website, www.kdocstudy.com. And so the goal of this study was to prospectively assess living donor outcomes. And so we want to look at medical outcomes, which are, as I mentioned, the All Told study is the other prospective study. And they're already looking in detail at medical outcomes. But we also wanted to look at surgical outcomes, particularly psychological and social outcomes, and cost issues in particular, and also functional outcomes. So very comprehensive data collection. And the idea is to identify donor and actually recipient factors too. So the idea is that for psychosocial outcomes, how well the recipient does could have a very big impact on the donor's psychological outcome. There's a very big difference if the recipient has early graft failure from noncompliance, for example, versus has a very good experience. And so we wanted to look at variables associated with outcomes and identify disparities in outcomes and what factors could be explaining these disparities. So our goal was to recruit 720 subjects, including 280 donors and the 280 recipients that would be associated with those donors, and also to enroll 160 healthy controls. And so I've talked about controls quite a bit. Our goal, and the NIH really pushed us hard to do this, was to have essentially the best possible controls. So the idea was to pick controls who had actually been completely evaluated to donate, actually approved to donate, but for some reason did not donate because another donor was used or the recipient got a deceased donor kidney. So these would be very high quality controls. But as I'll show you in a minute, those super high quality controls are actually very difficult to obtain. But this was the goal of the study. And the endpoints we used to assess was the same endpoints that data is already required to be pulled at the 1, 6, 12, and 24-month time points. So we started enrolling in 2011. Enrollment was closed in November 2013. And unfortunately, the NIH shortened our budget from 5 years to 4 years, and we were not able to prolong enrollment. So we actually were a little bit disappointed in the enrollment, the ultimate enrollment, but here it is. It's 189 donors and 151 of their recipients, but only 20 of the healthy controls. And I'm just going to show a little bit of the data. So we just finished the 2-year follow-up a few months ago, and there'll be hopefully quite a bit of data coming out of this, but just to show you some of the published data. So this looked in detail at the costs associated with donation. And so this looked just at pre-donation costs. So even before the donor is generously donates their kidney, they already have these substantial costs. And you can see that about a quarter of these donors had over $1,000 of direct and indirect costs even before donating. And this is not yet published, but it is in press. We also looked at the cost after donation. And so you can see direct costs are here. You can see that the mean amount was over $1,000 in direct costs. So this looks at transportation, lodging, meals. And then if you look at indirect costs, there's a number of different ways of looking at it. But you can count various actual wages lost, and then you can also ask potential wages lost. And if you look both ways, if you exclude paid vacation, you get this $1,600. But if you include everything, you get this almost $5,000 in cost. So this is really a problem. These are donors who are altruistically trying to help a loved one by donating a kidney, and they are asked to pay these substantial costs. And I think this is actually a major goal in the field of living donation, to try to do what actually a lot of other countries have done, which is defray these costs, and with the goal of financial neutrality is the term that we're using. But this is to document, again, in very great detail what the various costs are associated with live donation. So the last thing I want to talk about, and hopefully we have a little time for questions, is the UW Living Donor Program. And I'm not going to go into a lot of detail. I do think, looking at all this data that I've provided, we're still in a situation where the best option for someone with the SRD is to get a live donor kidney. But the idea is to assess the risk carefully. And so still, growth in the program is still a good thing. We still think that the risks are relatively low, the benefits are very high, so the growth is a good thing. But we're not willing to grow the program by being reckless with the various acceptance or exclusion criteria. So that's clearly not the goal. But what we have focused on, and I'll show you some data in a minute, is 2 approaches to get around the immunological barriers that have traditionally excluded a substantial proportion of potential live donors who want to donate. So these are ABO incompatibilities or HLA incompatibilities. So one approach has been paired kidney exchanges, and I'll show you a little more in detail. We've used a number of different programs. The NKR, National Kidney Registry, is actually it's a nationwide program. It's the largest program for paired exchanges. UNOS also has, so UNOS is the government program, also has a paired exchange program. And we've also increasingly started using our own internal paired exchange program. And we've also started using compatible pairs to try to increase the number of paired exchanges that can be performed. We've also used some desensitization approaches to overcome immunological barriers. The idea there is if there's an ABO or HLA incompatibility, to use very aggressive immunosuppression to try to overcome that. So just to be explicit, since some of you probably are not that familiar with the paired exchange programs, the general idea, this is really the simplest version, is if you have a donor who's blood type A who wants to donate to someone who's blood type B, he's therefore incompatible. Someone else is a B wanting to donate to an A is also incompatible. And if you do a paired exchange, you end up benefiting both of the recipients. And these can turn out to be, you can do 3-way exchanges, you can do change. There's a lot of much more complicated ways to have paired exchanges. Some of these incompatibilities can be HLA. You can mix and match. But the idea is that you can get all the recipients to benefit from these exchanges. And the idea was a little bit novel 10 years ago, and you can see there were fairly few paired exchanges done then. But you can see there's been a really dramatic increase, and this has actually continued in the last few years, so that now there's over 500 paired exchanges being done across the country. And if you remember the numbers, that's about 10%, close to 10% of all the live donor transplants in the country. And so we've been pursuing that approach as well, so that you can see the total paired kidney exchanges in the last 4 years went from 18 to this past year 36. NKR went from 18, slightly increased to 22. Where we've made a lot of progress is by starting our own internal exchange, so getting the computer program that will make the best matches. It's very similar to the residency matching program algorithms that there was a Nobel Prize awarded for in economics a couple of years ago. So we've increased from 0 to 13 of these internal exchanges. We've done a few exchanges with UNOS, and in the last few years we started using some compatible pairs as part of these exchanges. So, and the result of that, you can see in the previous 5 years of the program, we were able to do between 86 and 97 live donor transplants, and this past year we were able to do 118. So I think a success story. So I will, leave some time for questions. I think, so living donation is generally safe. Some concerns have been raised. Clearly, there is some risk associated with it, and the crux of the matter is making sure that there's informed consent. I think another key point is that some people have pointed out that there's actually a risk of not donating. So if someone who may have some medical complexity is told they cannot donate, they may not have the opportunity to donate to their spouse or child or somebody who they would get direct benefits from having that person be healthy. And this is something that we actually deal with. Sometimes potential donors are very upset when we think they're too high risk and they're not allowed to donate. So we continue to struggle with where to draw the line. And again, the next thing is that we really need better outcomes data to better guide us and better guide our patients in terms of what are appropriate exclusion criteria for donation. And then the last thing is that we clearly need further efforts to reduce the financial burden on kidney donors to facilitate motivated donors. Clearly there's some donors who are not donating because they are informed about the potential financial burdens and they're just not able to proceed. So thank you for your attention. A question?
Are there any health insurance policies that will cover costs of the donor as well as the recipient?
So the question is, are there insurance policies that will cover the costs, these donor costs? So there is a program, there's a key question. There's a program called NALDAC, National Living Donor Assistance something, that in the US covers some of these costs, some of the transportation, lodging, and meal costs. But it turns out that that program is very burdensome in a number of ways. There's means testing for both the donor and the recipient. So if a donor doesn't have money but the recipient is wealthy, this donor will not be able to access those funds. And in addition, that program, which is actually it's a government-funded program that's sort of administered through the ASTS, the American Society of Transplant Surgeons, but that program explicitly does not cover lost wages. And loss of employment and lost wages often are actually a bigger financial burden. So there's actually a number of models in Canada and in Europe where there's no means testing and lost wages are covered. And so a number of us are pushing to try to get to that stage, but we're not there yet.
You gave a very nice presentation. I really enjoyed it. And you contributed really wonderfully to this aspect of transplantation.
Thanks.
Congratulations on that. I'd be interested in your thoughts about the benefits of the whole living donor screening process in terms of how many lives are improved and saved by just individuals going through the screening process. That subclinical serious medical issues are uncovered that may have not otherwise, though they can't be a donor, they may actually have a substantial benefit having been involved in that maybe in the end outweighs the risks of the donors that go through the program if you look at it in totality.
Yeah, I think that's another great question. So the question is to people who are evaluated as live donors and who actually may not be able to donate, but that important medical conditions are found and that they have direct benefit from that careful evaluation. And that's definitely true. There's people who haven't seen a doctor in years. They consider themselves healthy, and they wouldn't otherwise see a doctor. But they get this very thorough evaluation. And, we've made diagnoses in this evaluation, everything from, cancers, breast cancer, colon cancers, to proteinuria, hematuria, issues that clearly need nephrological follow-up. We've picked up heart disease. Clearly, that's a side benefit. That's obviously not our main goal in the live donor evaluations, but I think it is a side benefit.
Is there any restrictions as far as age for the recipients to be transplanted? I heard that at a JERF meeting, and I didn't think that was true.
No, basically no. Different programs have slightly different approaches. I think most programs, and it's true, some programs do actually still have age cutoffs, but I think the overwhelming majority of programs evaluating recipients understand that there's this concept of physiological age that's more important than chronological age, and that if you have a 75-year-old who's running marathons and working full-time, that's probably a better candidate for transplant than a 40-year-old but who's diabetic and has had massive heart attacks, cardiomyopathy, so it would be a much poorer candidate. So I think there's some exceptions, but I think generally there's no age cutoffs. And actually that would apply to the live donor evaluation as well. So we have accepted, I think most programs have accepted kind of the unusual older donor. Again, when we do these evaluations, the older the donor, the more likely they'll have low GFR and be excluded based on that. But if they're 75 and have a great GFR and they're otherwise healthy, there's really no good reason to exclude them.
You've outlined the protections for live donors in this country. What's going on internationally, and is there a risk in some other countries for recruiting donors who might sign up just for financial reasons?
Yeah, definitely. That's been an area of very great concern. China in particular has had a very bad reputation for essentially harvesting organs from prisoners, really scandalous aberrations, I would say. There's been a lot of pressure put on China, and I actually saw an article recently that they claimed that they were going to completely stop doing that, and they made laws saying we no longer do this, but somebody did an investigation and found that that still is happening. And clearly there is organ trafficking, and that's a major focus, a very important focus of the transplant societies in the United States to try to minimize that and to not participate in that. There's all sorts of other interesting questions in the field. Iran has actually an organ market, and people have interpreted what happens in Iran very differently. Some people have said that this market is well regulated and everybody benefits. Others have argued that there's people who think their life will be changed by getting a couple $1,000s, and in fact their life after years is completely unchanged or often much worse, and that this is sort of inherently coercive. There is actually quite a bit of discussion in the United States about considering a regulated living donor organ market. I personally think that discussion should be very completely separated from a discussion about financial neutrality. So I personally am very skeptical of organ markets, even though it may end up that we do some sort of research studies on that approach in the United States. But what I feel very comfortable with is reimbursing donors for these various costs to prevent the main reason that they don't donate is a financial burden. And again, there's plenty of countries that I think have very good models about reimbursing lost wages and various costs associated with donating, and I think we should adopt those. Good. Thank you very much.